Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 203 of our Pharmacotherapy MCQ series, which is a collection of several clinical vignettes. And the first question reads, PNC, a 56-year-old male patient returns to your hospital for cardiothoracic surgery and receives unfractionated heparin during surgery. PNC was previously exposed to unfractionated heparin during hospitalization for medical management of acute coronary syndrome 3 weeks ago. 24 hours after surgery, PNC's platelet count had dropped drastically to 71 cells per millimeter cubed, which corresponded to a 48% drop from baseline, that is admission for surgery. The cardiology resident asks you about the possibility of heparin-induced thrombocytopenia, abbreviated as HIT. So my question to you is, which of the statements listed below would be the most plausible explanation for PCN's thrombocytopenia? Would it be A. This platelet drop is not from HIT because it happened on post-operative day 1, i.e., his second exposure to unfractionated heparin was for less than 5 consecutive days, or B. The platelet drop probably is from HIT, not the surgery, because he was exposed to unfractionated heparin within the past 100 days, in particular in the past 30 days, or C. The platelet drop could be from the surgery, but HIT cannot be ruled out because he was exposed to unfractionated heparin within the past 100 days, in particular within the past 30 days, or would it be D? The platelet drop could be from surgery, but it is not the result of HIT because his first exposure to unfractionated heparin was more than 14 days ago. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. The platelet drop could be from the surgery, but HIT cannot be ruled out because he was exposed to unfractionated heparin within the past 100 days, in particular within the past 30 days. I will justify why I consider this the correct answer. HIT cannot be ruled out because he was exposed to unfractionated heparin within the past month. Cardiac surgery is a risk factor for thrombocytopenia, but he may have HIT because of his exposure to unfractionated heparin within the past month. The cardiac surgery could have contributed to the thrombocytopenia. A second exposure to unfractionated heparin for 5 consecutive days is not necessary for HIT to develop if a patient was first exposed within the past 100 days, especially within the past week. Please advance to the next question. And the next question reads, MAC, a 74-year-old female patient experiences a sudden onset of diaphoresis, nausea, vomiting, and syncope. MAC is rushed to your accident and emergency department, and an initial ECG demonstrates ventricular bigeminy with ST segment elevations in leads 2, 3, and AVF. She has a past medical history significant for type 2 diabetes mellitus, hypertension, transient ischemic attack, dyslipidemia, and stage 2 chronic kidney disease. Her pertinent labs include positive cardiac enzymes. Currently she takes aspirin at a dose of 81 mg orally once daily, pravastatin 40 mg at night, metoprolol XL 50 mg orally once daily, losartan 100 mg orally once daily, and glimepiride 1 mg orally twice daily. So my question to you is, which of the interventions listed below would be the best treatment plan for MAC? Would it be A. aspirin 325 mg and prasugrel 60 mg at once, then prasugrel 10 mg once daily, UFH 60 units per kilogram bolus, then 12 units per kilogram per hour titrated to a PTT of 50 to 70 seconds, and eptifibatide 180 micrograms per kilogram bolus times 2 followed by an infusion of 1 microgram per kilogram per minute at the time of percutaneous coronary intervention. Or B. aspirin 325 mg and clopidogrel 600 mg at once, then clopidogrel 75 mg once daily, UFH 60 units per kilogram bolus, then 12 units per kilogram per hour titrated to a PTT of 50 to 70 seconds, and eptifibatide 180 micrograms per kilogram bolus times 2 followed by an infusion of 1 microgram per kilogram per minute at the time of percutaneous coronary intervention. Or C. medical management with eptifibatide 180 micrograms per kilogram bolus times 2 followed by an infusion of 1 microgram per kilogram per minute for 12 hours, UFH 60 unit per kilogram bolus, then 12 units per kilogram per hour titrated to a PTT of 50 to 70 seconds, aspirin 325 mg per day, and clopidogrel 600 mg at once, then 75 mg once daily. Or would it be D. medical management with eptifibatide 180 micrograms per kilogram bolus times 2 followed by an infusion of 1 microgram per kilogram per minute for 12 hours, UFH 60 units per kilogram bolus, then 12 units per kilogram per hour titrated to a PTT of 50 to 70 seconds, aspirin 325 mg per day, and prasugrel 60 mg at once, then 10 mg once daily. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. medical management with eptifibatide 180 micrograms per kilogram bolus times 2 followed by an infusion of 1 microgram per kilogram per minute for 12 hours, UFH 60 units per kilogram bolus, then 12 units per kilogram per hour titrated to a PTT of 50 to 70 seconds, aspirin 325 mg per day, and clopidogrel 600 mg at once, then 75 mg once daily. I will clarify why. Medical management would not be appropriate because of the patient's risk factors for CAD and ECG changes with positive cardiac biomarkers. In this patient, the presence of ST segment elevation on ECG with positive cardiac biomarkers for myocardial necrosis in addition to 3 risk factors for CAD, that is type 2 diabetes mellitus, hypertension, and dyslipidemia, suggests the need for urgent revascularization. An early invasive strategy should be used to determine whether the coronary arteries are partly or completely occluded, and an intervention with stent placement is needed. Finally, I would like to add that prasugal is contraindicated in patients with a history of a transient ischemic attack or stroke. Please proceed to the next question. And the next question reads, CRA, a 67-year-old male patient presents to your accident and emergency department. His chief complaint is crushing chest pain with radiation to the left jaw and arm. His ECG reveals a 3 mm ST elevation myocardial infarction. He has a past medical history significant for prior myocardial infarction 8 years ago, hypertension, dyslipidemia, and end-stage renal disease requiring hemodialysis. CRA is given aspirin 325 mg stat and clopidogrel 600 mg stat at your accident and emergency department and rushed to the cardiac catheterization laboratory for primary percutaneous coronary intervention, abbreviated as PCI. The patient is given clopidogrel 600 mg orally stat. So my question to you is, which of the following below would be the best antiplatelet and anticoagulation strategy for CRA in the cardiac catheterization laboratory? Would it be A. Abciximab 0.25 mg per kilogram IV bolus, followed by 0.125 mg per kilogram per minute, and enoxaparin 0.75 mg IV push stat? Or B. Eptifibatide 180 micrograms per kilogram IV bolus times 2, followed by an infusion of 1 microgram per kilogram per minute, and UFH, or C. Eptifibatide 180 microgram per kilogram IV bolus times 2, followed by an infusion of 2 micrograms per kilogram per minute, and UFH, or would it be D. Bivalirudine 0.75 mg per kilogram IV bolus followed by an infusion of 0.25 mg per kilogram per hour? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Bivalirudine 0.75 mg per kilogram IV bolus followed by an infusion of 0.25 mg per kilogram per hour. Bivalirudine is the best option in this patient with end-stage renal disease requiring hemodialysis because of the lower risk of bleeding compared with GP2B3A inhibitors. The use of eptifibatide is contraindicated in this patient with end-stage renal disease requiring hemodialysis. The use of enoxaparin is contraindicated in patients with renal failure. Continuous infusion of abciximab would have a prolonged duration of activity following a bolus dose, putting this patient at risk for bleeding. Please progress to the next question. And the next question reads, PAN, a 54-year-old female patient presents to your accident and emergency department. She has a chief complaint of respiratory distress requiring intubation and vasopressor support for cardiogenic shock due to ST segment elevation myocardial infarction. She has a past medical history significant for coronary artery disease, and type 2 diabetes mellitus. PAN received initial bolus of bumetanide 1 mg IV push to promote diuresis of 1.5 liters followed by the initiation of a dopamine infusion followed by norepinephrine due to hemodynamic instability. PAN is now oliguric with acute kidney injury secondary to hypoperfusion. Her other pertinent labs include a rising lactate of 4.5 mmol per liter, and an iron gap of 23. With regards to the ABG, she has a pH of 7.25, AP, CO2 of 23 and bicarb of 17. So my question to you is, which of the options listed below would be the best treatment option after PCI for PAN? Would it be A. Initiate continuous renal replacement therapy? Or B. Initiate hemodialysis? Or C. Initiate a bumetanide infusion at 0.5 mg per hour with no bolus dose? Or would it be D. Administer bumetanide 2 mg IV push followed by a bumetanide infusion at 0.5 mg per hour? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Initiate continuous renal replacement therapy. The patient has significant hemodynamic instability, and administration of loop diuretics, e.g., bumetanide, after PCI could potentially worsen renal function and the degree of acidosis, especially following contrast media administration. The patient has hemodynamic instability requiring vasopressor support in which IHD would not be tolerated. The patient has hemodynamic instability requiring vasopressor support in which intermittent hemodialysis would not be tolerated. CRRT is the best option to correct electrolyte abnormalities and the metabolic acidosis associated with an elevated lactate due to cardiogenic shock. Please advance to the next question. And the next question reads, ZAK, a 58-year-old male patient collapses watching his daughter's basketball game. On arrival of the paramedics at the scene, ZAK is unresponsive. His ECG points to ventricular fibrillation, VF. ZAK is defibrillated and the paramedics achieve return of spontaneous circulation, abbreviated as ROSC, after 10 minutes upon admission. Targeted temperature management, abbreviated as TTM, is initiated with iced IV saline and placement of cooling pads. ZAK begins to shiver within 30 minutes of initiation. His pertinent vitals include, a blood pressure of 95 systolic and 60 diastolic, and a heart rate of 105 beats per minute while receiving a norepinephrine infusion. So my question to you is, which of the following would be the best option for management of shivering during TTM in ZAK's clinical scenario? Would it be A. Give cisatracurium 0.15 micrograms per kilogram IV push times 1, followed by a continuous infusion? Or B. Start a propofol infusion at 20 micrograms per kilogram per minute? Or C. Give fentanyl 100 micrograms IV push followed by a continuous infusion? Or would it be D. Give morphine 2 mg IV push followed by a continuous infusion? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Give fentanyl 100 micrograms IV push followed by a continuous infusion. Morphine is not a good choice for this patient because it has an active metabolite and accumulation during TTM could worsen the patient's hypotension. Propofol is not the best choice for this patient because it could worsen his hypotension. Fentanyl is the best choice to manage shivering during TTM in this patient because it will provide analgesia and sedation. In addition, the drug has inactive metabolites, so accumulation during TTM is not as much of a concern. Consider use of analgesia and sedation strategies before initiation of paralysis. There is a risk of prolonged paralysis, especially with the use of a continuous infusion during the rewarming phase of TTM. C-satricurium, specifically, undergoes Hoffmann elimination, which is an enzymatic process that causes a prolonged duration of action. If paralysis initiated, it should be given as intermittent bolus doses before a continuous infusion is initiated. Please advance to the next question. And the next question reads, MDM, a 67-year-old male patient status post-ventricular fibrillatory arrest who underwent cardiac catheterization at your cath lab and was found to have an ejection fraction of 20% and an intra-aortic balloon pump is placed. Therapeutic hypothermia is initiated and the team comes to you to ask about initiation of a heparin infusion. MDM's baseline partial thromboplastin time, abbreviated as PTT, is 30 seconds, range 25 to 35 seconds. So my question to you is, which of the following would be the best recommendation regarding heparin dosing in MDM's clinical scenario? Would it be A. Omit the bolus dose and reduce the maintenance infusion? Or B. Reduce the bolus dose and maintenance infusion? Or C. Reduce the bolus dose without reducing the maintenance infusion? Or would it be D. Omit the bolus dose without reducing the maintenance infusion? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Reduce the bolus dose and maintenance infusion. Simply initiating a heparin infusion without a bolus dose is an option, but the safety of this approach would depend on what the patient received in the cardiac catheterization laboratory and the baseline PTT prior to the initiation of the heparin infusion. If a heparin infusion is initiated without a bolus dose, it would lead to a delay in therapeutic PTTs, putting the patient at risk. A bolus dose reduction without a reduction in the maintenance infusion has been shown to cause supratherapeutic PTTs, which may be associated with an increased risk of bleeding. Supratherapeutic PTTs, which may be associated with an increased risk of bleeding, have been observed during heparin therapy in patients undergoing therapeutic hypothermia. The best option to avoid supratherapeutic PTTs and an increased risk of bleeding is to decrease both the bolus dose and maintenance infusion. Simply initiating a heparin infusion without a bolus dose is an option, but the safety of this approach would depend what the patient received in the cardiac catheterization laboratory and the baseline PTT prior to the initiation of the heparin infusion. If a heparin infusion is initiated without a bolus dose, it would lead to a delay in therapeutic PTTs, putting the patient at risk. Please advance to the next question. And the next question reads, which of the pharmacokinetic alterations listed below is seen in patients undergoing extracorporeal membrane oxygenation, abbreviated as ECMO? Is it A. Unpredictable and prolonged drug effects due to binding? Or B. Increased plasma protein binding leading to a decrease in unbound drug? Or C. Decreased volume of distribution? Or would it be D. Enhanced elimination due to increased drug clearance? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Unpredictable and prolonged drug effects due to binding. ECMO causes a decrease and, not an increase, in drug clearance and elimination. The volume of distribution is increased, not decreased, during ECMO due to fluid shifts, drug sequestration, and increased cardiac output. There is a decrease, not an increase, in plasma protein binding, leading to an increase, not a decrease, in unbound drug concentrations during ECMO. A variety of properties influence the degree of drug binding to and release from the circuit components, including surface area of the tubing and membranes, type and age of the circuit, fluid used to prime circuit, and type of tubing, coated versus non-coated. All of these properties lead to unpredictable and prolonged drug effects. Please progress to the next question. And the next question reads, JWJ, a post-PCI patient has an ejection fraction of 20%, cardiac output of 3.6 liters per minute, and a pulmonary capillary wedge pressure of 26 mm of mercury. Your cardiothoracic surgeon successfully places an intra-aortic balloon pump, abbreviated as IABP, which is currently at 1:1. A dobutamine infusion is initiated at 5 micrograms per kilogram per minute. While trying to increase the dobutamine infusion, JWJ's blood pressure falls to 88/60 mm of mercury. A phenylephrine infusion is initiated. JWJ remains hypotensive despite increasing the phenylephrine infusion and requires addition of norepinephrine. JWJ's cardiac output has now decreased to 1.8 liters per minute. His oxygen saturation remains in the low 80% despite optimizing ventilator settings. So my question to you is, which of the following is the best option for device placement and management in JWJs? Is it A. implantable left ventricular assist device, abbreviated as LVAD, or B. percutaneous left ventricular assist device, or C. VV ECMO, or is it D. VIA ECMO? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. VIA ECMO. The patient is experiencing cardiogenic shock, and the best option is VIA ECMO to allow the myocardium time to recover. If after 48 to 72 hours there is no improvement in hemodynamics or cardiac output, it would be reasonable to consider placement of a left ventricular assist device, abbreviated as LVAD. VV ECMO is appropriate for patients with respiratory failure without cardiac involvement. Although a percutaneous left ventricular assist device is an option, it is not the best option because the patient is already optimized on an IABP conducting 1:1 with a continued decreased cardiac output. A percutaneous left ventricular assist device is typically considered temporary support during high-risk cardiac interventional procedures. An implantable LVAD would be appropriate for this patient, but it is not the best option because VA ECMO is less invasive and may be effective for salvaging myocardial function in this patient. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 204.